Hi, I'm Antonis Pavlidis. I'm a consultant interventional cardiologist and lead of the CTO service at St Thomas's Hospital in London. I'm going to present you a case of a 69-year-old gentleman who presented in the clinic with a 3-month history of a typical exertional angina. He had multiple risk factors for coronary artery disease, including type 2 diabetes, hypercholesterolemia, and positive family history. His baseline LV function was normal, and he underwent a coronary angiogram which showed 3-vessel coronary artery disease. This is his coronary angiogram demonstrating heavily calcified coronary arteries with a tight ostial LAD lesion and further disease in the proximal and mid vessel. There was also ostial occlusion of his circumflex artery and mid vessel occlusion of his right coronary artery. The patient was referred for coronary artery bypass grafting. He received edema to his left anterior descending, but during the operation he was found to have a porcelain aorta and it was not possible to graft his RCA and circumflex. He underwent a stress cardiac MRI which showed severe inducible ischemia in the RCA and circumflex territories, and he was subsequently referred for further revascularization with angioplasty to his occluded RCA and circumflex. He was admitted electively for CTO angioplasty of his right coronary artery. The proximal vessel was heavily calcified and there was a mid-vessel occlusion at the level of a marginal branch. The length of the CTO was 20 to 30 millimeters and the proximal cap was rather ambiguous at the level of the origin of the branch. The distal vessel appeared to be severely and diffusely diseased, and there appeared to be favorable septal collaterals from the left system. We used an 8 French AL1 guide as an antegrade guide, but due to heavy calcification of the proximal vessel, support was inadequate. We therefore inserted a cyan blue wire to a proximal side branch, followed by a 20mm balloon inflated at 12 atmospheres as an anchor balloon. The proximal vessel was transversed with a Fielder XT wire over a 135 cm Corsair microcatheter. We used a Gaia second wire to puncture the proximal cap, but then faced significant difficulties advancing a knuckled wire to the distal vessel due to the significant calcification of the proximal vessel. In order to overcome this difficulty, we performed the so-called Carlino technique with a tip injection of contrast via the microcatheter. This resulted in some dye extravasation proximally, but allowed us to advance a knuckled Fielder XT all the way to the distal vessel. We then proceeded with the retrograde approach. A cyan wire was utilized to wire the second septal over a 10-pike LP microcatheter. A cyan wire was then easily advanced to the PDA, and following that, a Fielder XT knuckle was advanced to the mid-vessel. We then attempted to deliver a 6 French guideliner to the distal vessel in order to perform guideliner-assisted reverse cart. Unfortunately, we were not able to deliver a 10mm balloon due to the heavy calcification of the proximal and mid-vessel. The Corsair microcatheter was advanced distally, and the Fielder XT knuckle wire was exchanged for a rota floppy wire. We performed rotational atherectomy with a 1.5 and 1.75mm bears. We subsequently tried to deliver a 30mm non-compliant balloon, but this would not fully inflate. We therefore decided to move the base of the operation to the proximal vessel, and a Gaia second wire successfully entered the antegrade guide liner. An RG3 wire was externalized, and we delivered 3.0 and 3.5mm non-compliant balloons which failed to expand the lesion. We subsequently delivered a 3.5 by 15mm high pressure balloon which unfortunately ruptured at 25 atmospheres. A second 3.5 by 20mm high pressure balloon was dilated at 30 atmospheres but failed to dilate the lesion. This was further dilated at 35 atmospheres, successfully expanding the mid-vessel lesion. The same high-pressure balloon was utilized to dilate the proximal lesion. Unfortunately, it failed to expand at 30 atmospheres and once more ruptured at 35 atmospheres. We used a third 3.5 by 20mm high-pressure balloon which successfully dilated the lesion at 40 atmospheres. This allowed delivery of several drug-eluting stents with the assistance of 6 French guideliner, achieving an excellent final angiographic result. The patient was readmitted electively for stage angioplasty to his occluded circumflex 8 weeks later. As you can see, the result of the RCA remained excellent and he went on to have recanalization of his occluded circumflex with antegrade dissection re-entry techniques, achieving another excellent final angiographic result. There are a few learning points from this case. First, complete revascularization can be safely achieved in patients with complex coronary artery disease with the use of advanced techniques and modern equipment. Second, hybrid revascularization with coronary artery bypass grafting and angioplasty is a useful alternative when either modality is not fully successful. And finally, the combination of rotational atherectomy and OPN balloons is very effective in treatment of undilatable lesions.